Okay, whenever you give me the go ahead, Tessie, we can go ahead and get started. Great. Well, good morning, everyone. This is Sally Bolin. It's nice to see and hear all of you today. I will be serving as the co-facilitator of the meeting, or the facilitator of the meeting as one of the co-chairs, I guess. So I will do a roll call. Leanne had a good suggestion on the agenda, so I'm hoping I did not miss anyone. I used the list, Alex, that was on the shared drive. So please correct me if I've missed anyone, but I'll just do a quick roll call so that Joe has that for the minutes. And I just listed everyone alphabetically. This is Sally Bolin. I am present. So Representative Rodney Creech.
Here.
Alex Lapso.
Here.
Representative Stephanie House. Okay. Joe Russell.
Here.
Leanne Smith.
Here.
Jean Thompson.
Here.
Pete Van Runkle.
Here.
Steve Wilson. Senator Steve Wilson. I'm sorry, Senator Wilson.
Not a problem. Steve's fine, and I am present.
Great. And then Amelia Jackson. I see Amelia here.
Yes, hi, thank you. I'm here.
Great. Good morning.
Morning.
And did I miss anyone? And if so, I apologize. Okay. Joe, are you good on the attendance? Okay,
Hi.
great. All right, good. I have a tendency to talk fast, so tell me if you need me to slow down. So I get myself in trouble sometimes because of that. So I guess just real quick, and I apologize, I just got the minutes out last night. But we will need to do approval of the meeting minutes. So if we can take a minute or two and take a look at those. And I would be happy to take any corrections to those minutes.
I don't have a correction really, Sally, but just in sort of maybe an add-on, and maybe I didn't even do it at the meeting, which is possible. That I really believe in the mentoring concept for learning, but one of the reasons I believe in that is that given the shortage of staff, for us to do a lot before someone even comes on may not be realistic. We need to bring someone on and train them. And I like the option of mentoring training, train them as they're there, because providers so often train someone, they actually work for 1 or 2 days and then they leave, or quite frankly, even sooner than 2 days after the first day. So that, a lot of training that happens beforehand is hard for providers to support. On the job training is easier to support. So I don't know the appropriate place for that. Maybe in today's review or something.
Yeah, no, I think that's a great comment. And I know that certainly, I'm sorry if I didn't capture that accurately in the minutes. I remember, I think a couple of people echoed that. So I think that's great that you brought that up, Jean. Thank you.
Thank you. Well,
Any
with
other,
that, I would move approval. I will move it.
Thank you, Jean. May I have a second?
Second.
Thank you, Pete. All in favor? You could say aye or give a thumbs up.
Aye.
Aye.
Okay.
Aye.
All right. Any oppositions or abstentions? Okay. Okay. Motion passed. Thank you very much for approving those. I just wanted to just take a moment to just review the agenda with the group in case there was anything we wanted to make sure that we added or reordered. Today we were going to discuss homework items number 9, 11, and 19. I know last week at the end of our meeting, we did talk a little bit about making sure that we had some discussion from the entire group's task force, from some of the comments that Director McElroy had made. So I didn't know if we wanted to insert those in the agenda or get through our homework first and just keep that added on, or if anyone else in the group had any other comments to add to the agenda before we get moving. No? Okay. All right, we'll just keep rolling along then. I did want to mention, because as I was, and I guess would just like to get some feedback from the group. I'm happy to continue to collate the homework because I can just do it, it didn't take that long, and put it all into one document if that would be helpful. I guess I was just, as we started to work through this process, I want to make sure that I capture people's information, but I just kind of merged everything that I had written out and Jean had written out and then Leanne had written out. And I know Pete added to that. Is that work okay? I guess it's a little clunky, but we're just getting thoughts down on paper right now and just wondered from the group, because I didn't want to be presumptuous or not record things accurately, and wondered if anyone had any thoughts about the homework piece of it, or if it's just too unwieldy as it is.
I think that's better than people submitting stuff on separate documents and then having to, somebody like you having to take that and plug it in. I think it's more efficient if the individual plugs it in themselves, and then you kind of ride herd over the whole thing to make sure that it's not getting all messed up or something.
Okay.
I'm in favor of that too. I already had put in though separately comments on the 9, 11, and 19. But in the future, I'll put all mine in on your document, Sally.
Okay, great. Okay. And then Alex, I guess I have a process question for you, because I didn't, there's several documents in the capacity folder that are, like Jean had submitted homework several times in separate documents before we decided to merge. And I didn't want to delete those because I didn't know if that was proper, but it's a little confusing having all those documents. Can we either put them in a subfolder or archive them or something? I just didn't want to do that because I didn't know if that was appropriate.
No, absolutely. That's a great question. I can go ahead and establish a new folder for those, and just so that they're kind of out of the way, and we can proceed that way.
Okay, great. All right, thank you. I didn't want to do anything improper, so okay, great. All right, thank you for clarifying that. Okay, all right, so we can move on to the next agenda item unless anyone has any other comments or anything they wanted to add. Nope. Okay, great. I'm going to go ahead then, and why don't we look at then point number 9, which is the number and availability of long-term care, dementia care units or providers. From the shared document, there were some suggestions. I don't know if you've all had a chance to look at them. Would it be helpful if I read those, or have you read them all? I'll give you a minute to look at them.
I think, Sally, just my comment was, I think those numbers are out there. I would assume, we should be able to tap into, I think I had, ODH, the Area Agency on Aging, the Alzheimer's Association. I don't know all of the organizations, but I feel like those numbers should be out there somewhere. I don't claim to know, the definition of them or the accuracy of them, but that was just my comment, are those organizations that obviously we can draw from. And I know Jean had some great comments on that as well. So
well, Scripps has some existing work, but I'm really thinking, since it's 219, so it was actually based on 218 information, that their study they're doing right now, which they said they might be willing to share some with us before it has an official report in June or July. I'd want to go from those. But Aging did provide, at least for the assisted living waiver, some good numbers on dementia care units. But I think Scripps would capture would capture all. And actually, Pete, I looked at a couple studies that include all the info for nursing homes too.
Thanks, Gene.
So I agree with you, Leanne. The information is out there.
Right.
So what is the best way to capture that, Gene? Is there a contact person at Scripps, or do we know?
I think, well, either Bob Applebaum or Jane Straker. Maybe Jane Straker's even, you know, Bob has sort of a whole lot of duties with Scripps, and Jane's more, maybe more intimately involved with the longitudinal study.
Okay, thanks.
I was wondering, you know, I think I understand what long-term dementia units are, but I was kind of curious in regards to, I just don't know what we meant by long-term care providers. Does that, and I just was kind of curious what that, if there was a definition for that, because I think that could be pretty broad, but I didn't know if we were just talking about more like facilities.
I wondered the
Depends if
same
you're-
thing because the previous question we talked about community-based providers. It makes sense, and respite care. It makes sense that this would be focused more on that, but it's not clear.
I would tend to agree, Joe, with your comments, although I think number 11 that we're looking at offers, see, to me, there are lots of assisted living options beyond assisted living in terms of dementia care. To me, it just means providing assistance or support, and that could happen in lots of venues.
I think if you're talking about number 9, I think that question is about facilities, and because it refers to units, and I think the use of the word provider there just refers to a facility that is 100% memory care, like Foundation Park as an example, or Columbus Alzheimer's.
Would you agree, Pete, that on number 11, though, we could capture other formats?
Well, number 11 is about assisted living, right?
Well, yes, but what I'm saying is maybe the term, when it says assisted living options, means, to me, it could be beyond just facilities. I tend to see 9 the way you're saying. I think that's about facilities. And number 11 mean, I don't know. Maybe that.
I guess you could read assisted living more broadly. I read it as meaning assisted living as we commonly understand it. And I thought number 8 was really what was about home and community-based services, because that's what it says. So I would think that if we're trying to plumb stuff in here, I would say number 8 is where anything other than and maybe a mention could be made there that assisted living is considered a home and community-based service, but it's also dealt with more specifically in the other questions, and that this one should, the detail in this one, in number 8, should be about non-assisted living home and community-based services. Then number 9 would be both assisted living and SNF. And any other, I don't know that there's any other kind of facility that we could really refer to. I don't think there are hospital memory care units. That's just not what they do. And then number 11 then focuses specifically on assisted, what I think is assisted living, which is a little bit redundant with number 10, but it's broader because not everybody with dementia is served in a memory care. I mean, we all know that. I mean, my mom was a perfect example of that. She had significant dementia, but never was in a memory care unit per se.
I like your separation, Pete, because maybe that helps us to get to a point.
Yeah, that was my thought.
Yeah. Okay. Any other thoughts from the group on this issue? Any other comments under this topic that we want to make sure that we cover?
Hey, Sally.
Yes,
me.
yeah.
Oh, I just wanted to echo Pete's comments. I think he really kind of broke that down. I know it gets a little confusing when we talk about the different types, of the living situations. And so assisted living, I would agree, is part of a home and community-based service, especially if you're talking to, ACL. But I think here maybe because of the topic, it might be appropriate to break it out and kind of that, ACL, or excuse me, assisted living is kind of another part, I guess, of home and community-based services, just because HCBS is so broad. So
Yeah. And I also think that this whole aspect of, although home care certainly can fall into this too, is the whole concept of 24-hour care. I know running an adult day, our adult day is open for 10 hours, but that's a whole lot different than 24, so it's kind of like a whole new ball game when you're a 24-hour facility, I think. And so that could also be maybe part of the factor with the breakdown. So I think that's a great point.
I would plop adult day into number 8. So it's not purely home care. It would include adult day, and well, of course, respite's already in there.
Yeah.
So
yeah,
it can be a little bit
that's
broader.
Great. Yep, great. Thank you. Any other comments? This is a little, one of the other things I was just wondering about, and I guess I'd be curious if any of, because you all are more the experts in that, but are you seeing any changes in landscape with the special care units because of COVID, in that maybe they're being closed? I'm just wondering, closed down, and is that something that we're going to need to wrestle with, that we think at all in the next year or so? I know adult day providers have been very slow to open up, and some providers around the state are saying they're not going to open up till 2022. And I'm just kind of curious as if it's affecting your industries at all, and something that we may want the consultants to make sure gets folded into all this. I'm just wondering and just asking the question because I was thinking about it this weekend.
In terms of assisted living, and we have been trying to track that, any assisted livings that have closed as a result of COVID, just quite frankly, the expenses of it, etc. And a few have. Not as many as I would have suspected. I do think a lot of that depends on what happens throughout the remainder of 2021. And in terms of, lifting of restrictions. Just imagine what this has done. Assisted living was a format where tours were the major source of entries. And so, of admissions, new admissions, people didn't want to move into a place they never even walked into, no matter how great your virtual tour was. So, there have been, lots of issues that way. I have not noticed, as I said, only a small number closed. I do think people have been increased costs like hazard pay, et cetera, et cetera. I would think that admission to assisted living waiver memory care units has way decreased because the reimbursement is so low. Aging said there are, in the waiver program, 871 dementia care units are certified, and there are clearly not 871 waiver clients being served. So that's probably the provider, which I do think you addressed really well in the minutes, Sally. They have to make a decision. They can't afford to do it for that reimbursement. So that is a huge aspect.
Yeah, just to add on to what Jean said, I think there's a fundamental difference between assisted living or skilled nursing, if a memory care unit, and adult day. As you said, adult day has been just devastated by all of this. because of having to close down. And we see this on the DD side as well. That there's just a lot of people who previously were using those services aren't using the services at all, and the providers are not operating. Assisted living and skilled both that were operating memory care at the time when COVID started, that was not an option. I mean, I guess it is an option if things get bad enough. And I agree with Gene. I haven't heard of a lot of providers going out of business. There have been some, but that's more of a general thing for the facility. I haven't heard, truthfully, of a single provider who has shut down a memory care unit, but continued to operate as a facility because of COVID. The demand, census is clearly down significantly. I don't know if Gene has a good sense of what it is in assisted living. I think it's probably something. The reduction has been something less than it has been in SNFs, but still there because people passing away and not being able to backfill with new admissions because of things like not being able to do tours or just general people putting it off. And I don't think that there's been a loss of memory care units as in any significant way.
I agree, Pete. I think if there's been a loss, it would only be in potentially, and I'm not sure, that in the waiver category of dementia care placements. Dementia care actually, even during COVID, that has often been an actual really need-based placement. Like if someone was living at home with their husband and had significant dementia, but their husband passes away and their children are all out of town, they're really viewing that placement in the memory care unit. That's really a need, an immediate need. So, and generally, it's a 24-hour need. So really, that's actually been an area where maybe there hasn't been quite as much, quite frankly, hesitancy if that situation developed on the part of families in terms of moving into a unit, a family member into a memory care unit.
Yeah, I would agree, conceptually, but I don't think we have any data whatsoever.
Well, I'll use one of your words, Pete. Anecdotally.
Anecdotally, thank you.
Great, thank you. Leanne or Joe or Representative Creech or Senator Wilson, I don't know, before we move on, if you have any comments or anything you want to add to the discussion about number 9?
No, I think that you're going down a good road there, and that you're on top of it. And I'm fine with where you are.
Same here.
One comment I would just make, and I don't know if it's appropriate to capture it here somewhere else, but I think it's worth considering other sorts of programs for people with dementia-related diseases that may not be totally being utilized today in the state of Ohio. For example, one thing I've been reading a lot about is the memory cafes, and having these programs where they're not necessarily like a strict day program per se, like as I understand it, but having more programs that are unique in the sense that they're not necessarily every day, but they offer an opportunity for people to get out into the community, but also interact with one another. I think it's worth keeping that in mind about what other alternatives are there to these types of programs besides just a caretaker taking care of someone or something like that. I don't know if that made a whole lot of sense, but I just thought it was worth mentioning.
Yeah, Joe, I think that's a great point, and I would agree with you on that. I know the state of Massachusetts has a whole network of memory cafes, and it's pretty cool to see their motto because in different communities, different organizations and individuals are, these are percolating up, and they're doing some really great things. So I think that's a really great point, and I think there's resources out there where we could learn from those types of things. I don't know if Amelia, you have any thoughts about that. I know ACL has a whole bank of information of those types of programs. I don't know if that's where you look, Joe, or not, or if you had another resource, but.
No, I think ACL might be a good resource to go there to kind of research some of those types of programs.
Yeah.
Sally, I'm good with all. Yeah, I'm good with all comments. Some great discussion, and I really don't have anything further to add at this point.
Okay, great. Okay, if it's okay with the group, then we'll keep moving just for the sake of time. Move on to number 11, which is assisted living options for individuals with Alzheimer's disease or related dementias. Jean, I know that you've provided some great comments on this, and so has Leon. If you want to take a moment to look at the comments, and then if there's any other additional thoughts or anything that has come to you that you might want to add.
Well, there's a typo in my comments, Sally. It should say AL.
Where is it?
AL memory unit unsecured, and then I meant to say secured. I mean, there are both types of those, but I said unsecured and unsecured. Must have been doing this late at night.
I'll fix that.
Thank you. Yeah.
And really, the only comment I had, the main comment I had, obviously, we know we need more affordable options in all areas, right, for people that are paying privately and maybe not able to be on the waiver. But my other comment was just that I think in my experience, in my personal life with my mom, by the time a person can get to that, point of care, sometimes assisted living is out of reach. It's because there maybe aren't memory care, specific memory care units in a lot of the assisted livings. You do the, you go through the admission requirements. The nurse comes and meets with them, does the assessment, and they're beyond assisted living. So that was just kind of my comment, that sometimes by the time a loved one needs that 24-hour care, they need to be in a secure unit, and maybe there just aren't enough of assisted living secure units for people that need that. There's long-term care. There's but in my experience, that's just what my comment was about. So
I would add, Sally, that I really feel that that many more are going to, we got kind of blasted, everyone, all levels of care of everything with COVID. But I think as we move out of that, actually the growth in assisted living and even in memory care and assisted living has been meteoric, actually, prior to COVID. And I anticipate that once we are, gosh, doesn't it sound wonderful to even suggest that once we would be through COVID, that I do think more are going to be added in that, because clearly the demand is there.
Mm-hmm. Great. Thank you. Any other, anything else that people want to mention or bring up around this point?
I would just go back to what I said a little bit ago under this particular, under number 11, that we need to recognize that memory care isn't the only place in assisted living where people with dementia are living, and they maybe haven't gotten to the point where the family feels like they need a secure unit, or maybe more to the point, that's not that's not what they do. They don't wander. So, again, going back to my mother was, she would follow the rules. They told her don't go outside. She didn't go outside, and so they didn't have a problem with letting her. She could wander around inside the building. It was all good, and she didn't have to be in a secured unit. So I think we have to recognize that there is, you know, and this is I'm somewhat stealing one of Gene's talking points. You know, the vast majority, maybe I shouldn't say vast, but a majority probably of people in assisted living have some kind of memory impairment, whether it's very beginning stages or whether it's further along, and they just haven't exhibited the kind of behaviors that would result in going into a memory care unit per se. So, and I don't know what the percentage is. Maybe that's something. There's probably some information out there on that too, but I would just add that to the pile.
Yeah, I think that's a great point. Thank you, Pete.
I'm still held up on that Pete's mother actually followed the rules. That's surprising, Pete, knowing you.
Yeah.
I do think you bring up a good point, because I know when I meet with families and we talk when we're transitioning to a different living environment, you don't necessarily always have to go to a memory care unit. You're right, and they still can get wonderful, excellent care and still have, a good quality of life. And so I think that's an important part to keep in our thoughts. So.
I would just like to add, similar to the point I made before, thinking a little bit more outside the box here. And I hope I'm not speaking out of pocket to Gene or to Pete, who represent assisted living, but we've been seeing the growth of the village concept, where it's kind of looks like, I guess maybe we'd categorize it as a non-secured sort of assisted living, where there isn't necessarily a nucleus to the village, but instead there's wraparounds for people who are living there. And we've actually seen them in other states where they're integrating people with different types of ailments, right? Disabilities and memory. But if there was the village concept was specific to dementia, memory related diseases, I could see there being a network of different providers that are able to provide services, and we kind of get outside of the licensing and some of the regulatory requirements. So I think that's an interesting concept, and both of the things that I've said in this in the last segment is rooted in the belief that I have, which is we're not going to be able, in my estimation, to publicly fund all of this. I think that it's really going to be important for us to have funding available to people and support them who can't. But I think there are a lot of people who are perfectly willing to support their loved ones financially through this process. They just don't have a ton of options. So I think it's worth us thinking about what options we can create through public policy that aren't necessarily funded through the public. So just kind of want to throw that out there.
That's a great point, Joe. Thank you for bringing that up. And, that's a great thing we should add to our resource list, is exploring some of the villages concepts for sure. Yeah, I think that's a great point. Okay.
I would interject one thing, and I like the idea of looking at the villages concept too. The one thing I would say, but maybe even within that village, in my experience in memory care and assisted living, that people, and actually I can relate a personal experience. When I started in all of this longer ago than I'd like to say, I actually went to the East Coast and stayed from Monday through Thursday in assisted living communities that were this more modern concept. And when I stayed in all memory care buildings, it isn't, and I found later when I actually came back here and worked, that people in those age ranges who don't have memory care losses, they really don't necessarily want to be with people who have significant memory care losses, because one of the reasons they come is for a socialization that doesn't happen for them with people with significant. I mean, certainly there are lots of stages moving up to significant memory care loss. I mean, I remember, and I'm sure many of you do, Roland Hornbostel with the Department of Aging. in the beginning of assisted living, he thought you could just kind of, with the concept they do in schools of mainstreaming, putting everybody together. But and so that was tried for a number of years in the beginning of modern assisted living in Ohio, but it really didn't work. And and so ultimately that's where we went to memory care units and to all memory care buildings and those kinds of concepts. And I think it's because some older people sort of feel, gosh, they even say it about with the vaccination, because they want greater freedoms in their life. It scares them to be with people with significant memory loss that they don't have it. If they're which we could say it shouldn't, but I think the reality is it does.
Thanks, Jean. Okay. Any other comments or about number 11 from the group?
I would say, I was just thinking about this and going back to what Joe was saying. We actually have a bit of a deficit on this group because we don't have anyone from Leading Age on it, and they represent, senior housing, affordable housing, and in many of those places, as I understand it, we don't really represent them, that space either. But as I understand it from listening to Leading Age folks, they've got places that are that there's some degree of services provided, or at least arranged for, and it seems like that kind of somewhat parallels what Joe was talking about, and is something that, if we're kind of doing a catalog of everything that's out there, that's a pretty significant thing that's out there. That you have places where folks are living, seniors are living. Some of them probably have some degree, and undoubtedly do have some degree of memory impairment. And there are some kinds of services that are being brought in or arranged in those settings. So I think it's just something we should make a marker on that's part of the scope as well.
This is Senator Wilson. May I make a comment?
Yes, please.
So I agree that dementia services are provided in a lot of different spaces at a lot of different levels. And I don't think it's harmful to make mention of that and to acknowledge that. Where I have a difficulty is when that dementia has reached the place where that person has to be protected from themselves. In other words, they have to be, quote unquote, locked down, or they have to be in an environment where they're not going to wander off. How do we make that distinction between that level of care and other levels of care to people who are suffering from dementia, Alzheimer's at an entry level?
I would think we have to create a progression of possibilities that mirror that potential path.
Right. I would agree too, just because there's so many facets of this disease, and as people progress, sometimes people can be at risk for harm because of various issues, but it could last for 3 months or 6 months or a year, and then it's no longer present. And so it's it's a trajectory for sure. And unfortunately, you know, everyone is different. I think what happens because of the tragic circumstances, that's often what you hear. But I think there's a significant amount of, and that's what we hear about because it's tragic and it's awful, and you don't want anyone to have to go through circumstances where they drive 3 states away, or you know, different things like that that happen. But at the same time, I think there's a lot of individuals who might be more, you know, like Pete's mom. My mom was like Pete's mom too, you know, and so that's I think you have a spectrum of services, you know, as best as you can to support individuals where they're at. I don't know if anyone has any other thoughts or comments, or does that make sense, Senator Wilson?
Yes, I was posing a question. I certainly didn't have an answer or even a suggestion, because this is just not a field I'm in. But it just appears to me that you have people that can operate independently but need services, and then we ought to recognize all the services that are available. But then you reach a point, and you reach a point where, for your own safety, you need to be protected. And I think that's a different category. And I don't know how we verbalize that, or how we put that in writing, to say that when it reaches this point where they need to have this level of care, then this. Because I think there's some different things that happen in that regard than happen at the person that's at home getting services, or assisted living getting services, etc. Again, Pete, you probably are better at this than I am, or somebody from leading age, but it just seems to me there's a big difference there.
Well, there is, and to make it more complicated, some of that depends also on the natural supports that are available or not available. Because you could have a person who needs that kind of supervision, but they have a family that's able to do it for them, for whatever, you know, whatever reason. Maybe there's enough of them, or you know, they're able to. And then you have folks that aren't, and kind of a gradation of in between. So you get into things like adult day, where, okay, yeah, I can handle it, but I can't handle it all day. So, you know, the person has to go somewhere for part of the time, or maybe it's 24 hours because there's just no one. So, you know, we have, it's not a really black and white thing that's like based on a level of care, because there can be other ways of meeting that level of care, you know, through, like I say, the natural supports.
I understand that. I guess I would say that we need to support the caregiver, whoever that is, be it the family, be it home health with 24-hour supervision, be it nursing care, where that person is when they no longer can protect themselves. It seems to me like there's an additional level of support that we need to give. You know, once a family gets to that point, they need help. And that was a lot of what we heard when we had the witnesses in for the Alzheimer's bill, was that, how can I do this? I need help. So I don't know how to do it. I just think there's a distinction there between a person that can be given services and is safe, and a person that has to be kept safe.
Okay. Any other, I want to, any other thoughts, comments before we move on to the next? Thank you, Senator Wilson. I think that's something we need to reflect in the notes and continue to chew on and develop recommendations for. If it's okay, because we've got about 13 minutes left, and I want to get. I think this is our last point for today. But if we could get to number 19, which is increasing the number of healthcare professionals necessary to treat the growing aging and Alzheimer's disease and dementia populations. I know that there's some comments on the homework, but I guess I'd like to open it up to the group and see if there's any other thoughts about this. This seems like this has been an issue that continues to grow and we talk about for the last 25 years, but I think it's something we need to continue to address. Anyone have any thoughts?
I can start the conversation a little. I just think it goes without saying. We all have talked about it in many different arenas, many different areas. There's obviously a shortage of healthcare workers across the board. But it takes a very special person to work with Alzheimer's and dementia patients. And so I think the training, as Jean mentioned earlier on the job, I had put that, I think, in some of my notes, that they need to be in the thick of things, for a lack of a better way of saying that, but they need to, it shouldn't really just be online training or just different classes. They need to be with those people that are suffering through these struggles each day and learning how to redirect and how to, maybe hopefully alleviate some behaviors that can happen. So all of that being said, I don't know how you increase the numbers. Some of my notes were to, start in middle, start to educate students of a need as they, have them looking in that direction, see if they're that person. Offer specialized college degrees, which maybe those are out there, and I may not be aware of what all, people can do these days, but it's just, I guess to increase the numbers, I feel like you have to increase the knowledge of what's out there, of, what the need is, I guess. And I don't know, I can't certainly say the best way to do that, but I know all of us, anyone that's in healthcare right now feels that struggle of getting workers. I also feel like, having their pay being commensurate with some specialized training, may help in that effort. But again, I think Joe had mentioned as well about, are we able to fund all of this stuff? So probably some across the board comments, but that's just my initial thoughts on that.
I'll just jump on following Leanne, and I think that we have to recognize that what these folks get paid is critical to whether you can find them, whether you can bring them in. And as she said, we're facing this across all of healthcare, into DD services, into everyone we all represent, and a lot of it stems from these many of the folks that are delivering these services that we've all recognized are so are not easy. I mean, these are things that you need knowledge, you need a sensitive heart, you need a lot of skills and a lot of attributes, and yet we're paying these folks, $10, $12 an hour to deliver these services, and it's just you're especially in the world we're in right now, but this was the case even before COVID. It's really hard to find people who are good and who have the necessary attributes when you just can't pay them very much, and then there's all those questions of benefits, et cetera. You go on down the line. We even find ourselves in situations where, okay, the person doesn't want to get paid more, because then they'll lose, they're getting government benefits, like they're on Medicaid, for health care, and they would lose that if their income went up. So it's complex. But I just feel like, whatever we can say about training and anything else, to get workforce, you have to be able to pay the people. That's just really the bottom line of it. And so, funding is challenging because there's lots of demands for funding, but without it, it's just, there won't be progress in this area. There just won't.
I agree with everyone's comments, and I don't know why, but I guess when I saw the term health professionals, for whatever reason, I didn't look at the whole spectrum of healthcare workers, and which I agree is the major issue facing all varieties of healthcare. But I kind of focused on physicians. Like, I really feel that we are not getting enough physicians to move into geriatrics. And I think there are reasons for that, which kind of are the same maybe for all healthcare workers. They don't necessarily see it as a field to enter because the payment source is generally all Medicare and Medicaid. I kind of thought that there should be an establishment of educational loan forgiveness if a physician studied geriatrics and moves into the field and stays for a certain amount of time. That was done actually in the past with physicians when they would serve underserved geographic locations in the United States. So something like that could happen. I mean, I actually even think just your primary care general physicians need to at least be studying somewhere along the line modules on aging and dementia. But I agree completely that just the overall workforce shortage is the major problem for healthcare right now. An impact on this potentially in terms of all healthcare workers are really immigration policies, etc. The bringing, but I'd like to see those policies made easier and extended beyond, say, nurse level immigrants, but even people at lower levels than that, because where we are seeing a huge dearth in terms of staffing is a lot on the front line staff. In addition to other areas.
Yeah. Thank you, Jean. I don't know, Joe or Representative Creech or Senator Wilson, if you have anything to add to any of this. Any comments?
I just would echo the comments that have already been made. I mean, the inability to recruit and retain workforce is the trying issue in healthcare, especially within home care. I know I've said this a billion times, and I'll continue to say it a billion times until it changes, but our skilled reimbursement rates are less today than they were in 1998. And, healthcare is subject to market forces with supply and demand, and the demand is gigantic and there's no supply. And that's forcing providers to make very difficult decisions about who they're going to serve. Even if they want to serve a Medicaid population, if they're losing money on every visit, it just, at some point, it's soon going to break. And so I think my view on this is, I think we need to take a holistic approach. I definitely don't think that just throwing money at wages is a silver bullet, although that would make a very strong impact. I think looking at getting high school students who might be interested in a healthcare career into a technical program so that they can begin working in healthcare while they're in high school as maybe a part-time job would help a lot. Looking for college students who, they may not, I'll use a home health aide as an example. Maybe they're not going to be a home health aide for their whole career. Maybe they're going to go on to be a doctor, but that experience working with people at the community-based level would be huge once they get to that level. And then, of course, looking for people who fall into the lower skill set range. Maybe they have worked in fast food for a long time, or maybe they do other low-skill jobs where they're struggling to get increases in pay. Might be an opportunity again to get their foot in the door in a healthcare career, which could help out these industries a great deal. So I think more resources needs to go in. There needs to be some type of public campaign in my mind to attract more people to healthcare, because I don't know that the general public is totally aware that there are so many opportunities in healthcare. So that's what I would add.
This is
This-
Senator Wilson.
Okay.
What I would add is the fact that healthcare is not the only place there's a workforce shortage. So we're competing not only in the healthcare area with people that may not be coming back to work because they would lose money to come back to work because of the unemployment benefits, all the things that we've talked about. But we're competing with every industry out there because there is a global, at least in the United States, a major workforce shortage that is holding back our economy. You add to that we see the newspaper articles about one of the most dangerous jobs in the world, is in healthcare. You take a look at where the wages are. I think that is a factor. And we have a major problem here we've got to address. When we went into the Alzheimer's bill and had the testimony, workforce wasn't near the issue that it is today. So that has changed dramatically. What was the issue was that we were losing beds at a time when we were going to need more beds because of Alzheimer's. And that hasn't gone away. What has changed is the ability to get workers. And I don't know that there's anything more important to every level of Alzheimer's and dementia care, whether it be assisted living, in-home, etc. No matter what, workforce is the big issue today, and we've got to come up with some suggestions in that area.
Yeah, this is Representative Creech, and I'm sorry I've been really learning a lot, and I like Senator Wilson said, this is not my wheelhouse, but I would 100% agree when it comes to workforce. Now we're getting into my wheelhouse, I guess. But not only do we have a short workforce, but I think I've seen the workforce change. And going to Joe's comment, making $12 an hour or $10 an hour, what we're seeing at our business is people are saying, well, if I'm only going to make that much money, I might as well go do that. So, they're looking for less stress, and this is a stressful business. We're seeing it in all of our social services. People are just jumping out because they can go work at McDonald's and make the same amount of money. I agree workforce is going to be a problem, and I think that's something we're going to have to focus on. I don't know if pay's the answer, but we are seeing this across the board, and it's not good.
I think we have to offer more. I agree. We have to offer more career paths within healthcare, but doing that means we have to have a constant influx. Going to some of Joe's comments on, through programs in high schools, through programs, through, part-time college students, because if you're going to create career paths when someone first comes into healthcare in an entry-level job, you're going to have to keep replenishing that as they move on through that career ladder.
Yeah.
Just a note, and I guess you heard this too, Gene, when we talked with Director McElroy on Saturday, that there apparently is a workforce group of some kind that is in the process, is forming. I believe Director Davis is chairing it within a cross agency administration effort. So not that they have all the answers or anything, or even started to try to come up with them. I just wanted everybody to be aware that that was going on, and maybe that could be somehow connected to our work.
Yeah, that's a great point, Pete. Thank you for bringing that, and thank you all for your comments. I was going to ask the ODA folks if there was any other cross collaboration occurring at the department levels, whether it was with education, DD, because as Representative Preach and Senator Wilson has said, this is cutting across all, every aspect, I think, of of any operation of business. And I know we're over time, but I think it might be something, maybe we can spend a little time next week if there's any thoughts, comments about this. Because I want to be, I imagine some people might have other meetings they need to go to, and I want to be respectful of time, but is that okay if maybe we hear from ODA folks next time on? I'd be curious, and maybe a little bit more about, Pete, what you've learned too. So it looks like for next week, we're almost to the last few numbers of our list. So number 21, we need to reflect on number 22 and number 28. So I don't, do you think we want to try and meet next Tuesday? Or if that works for people at the same time, and try and get through these last 3 issues, as well as finish our conversation on workforce, and then we can figure out next steps from there? Or is that not good for people?
I think it's okay.
It works for
Okay with
me.
next Tuesday.
Is that okay? Okay.
I'm
Sounds
fine.
like it's okay. So we'll maybe try for next Tuesday and try from 8 to 9 again. And we'll finish up the conversation and then figure out next steps from there. I'm anticipating, and I don't know, Alex or Tessie or Amelia, I know probably the consultants were anticipating they won't be in until June. Is that still a fair assumption?
June is
Great,
right
thank
around the
you.
corner.
Okay. All right. Any last comments before I think we go ahead and adjourn? I think we had some good discussion today. Leanne, are you good to chair next week's meeting?
Sure, I can do that. That's no problem.
Okay, great. Great. All right.
Do you think that, can we just kind of keep the same agenda going? I mean, and then, so once it's on the drive, I mean, we can just change the date on it or whatever for the meeting. But I think if everybody's okay with that, keep that same agenda. And then I think the only thing you had on here, Sally, was who was going to be kind enough to take minutes.
Oh, yes.
Now, don't everybody jump in there at once. I know I need to take a turn, but I will probably have to do that when I'm not facilitating the meeting. So if you would like me to, Sally, I can do minutes next time and you can facilitate again, or whatever works best for the group.
We can flip for it too. I can take minutes or do either or. Either's fine. So
okay.
It'll cause me to talk less, which is never a bad thing.
Okay, we can discuss that.
So, okay, that sounds good. Okay, great. So we'll plan on doing that, and we'll finish up our workforce discussion. And then I don't know about next week, but maybe the following week we can kind of raise some of those questions that we talked about in the larger group at the subcommittee level, and go from there too. I don't want to lose sight of that either. So, okay. All right.
Thanks, everybody.
Thank you. Have a
Thank you.
great day.
Bye, everybody.
Bye-bye.
Bye. Thank you.